Good morning, Rosa. How are you holding up? That was a long night.
Good morning, Maya. I am okay, thank you. A little tired, but okay. I am ready to give you the report now.
Perfect. Take your time. There's no rush. We have about 15 minutes before the day team is fully in. Go ahead whenever you're ready.
Okay, so I want to use the SBAR format, like we practiced. Is that correct?
Yes, exactly right. And Rosa, for our listeners who may not know, can you tell me what SBAR stands for? Walk me through it.
Of course. SBAR stands for Situation, Background, Assessment, and Recommendation. It is the standard format we use in nursing to communicate about a patient clearly and efficiently.
That's perfect. And I want to add, SBAR is used everywhere in American hospitals. It doesn't matter if you're calling a doctor at 2 in the morning or handing off to the next nurse. SBAR keeps everyone organized. It prevents miscommunication. In the ICU especially, miscommunication can cost a patient their life. So we take it very seriously. Okay, Rosa, go ahead. Bed 4. Start with situation.
Yes, okay. Bed 4, Mr. Harold Kim, 67 years old, male. He was admitted 2 days ago with community-acquired pneumonia. Situation: Mr. Kim had a difficult night. His breathing became more labored around 2 a.m. He was anxious, and his family called me to the bedside twice.
Okay, good. Background?
Background: Mr. Kim has a history of COPD, type 2 diabetes, and hypertension. He is a former smoker. He has been on IV antibiotics since admission. His chest x-ray yesterday showed bilateral infiltrates.
Good detail. Assessment?
Assessment: I am concerned about his respiratory status. His O2 set dropped to 89% at 2:15 a.m. I increased his oxygen from 2 liters to 4 liters per nasal cannula, and it came back up to 94%. He is stable now, but I would watch him closely.
Good catch, Rosa. And O2 sat? Let's pause there for a second. Do you feel comfortable explaining what that means?
Yes, OSAT is short for oxygen saturation. It tells us the percentage of hemoglobin in the blood that is carrying oxygen. We measure it with the small device we clip to the patient's finger, the pulse oximeter.
Exactly. And a normal O2 sat for a healthy adult is usually 95 to 100%. Now, for a patient with COPD like Mr. Kim, we sometimes accept a slightly lower baseline, maybe 88 to 92%, because their body has adapted over time. But dropping to 89 suddenly in the middle of the night, when he was previously sitting at 94, that's a change. And in nursing, we respond to changes. You did the right thing increasing his oxygen. Good instinct.
Thank you, Maya. That is helpful to understand, not just the number, but the trend.
Exactly. The trend. Always watch the trend, not just the snapshot. Okay, recommendation?
Recommendation: I recommend continuing to monitor his respiratory status every 2 hours. I also recommend notifying the physician if his O2 sat drops below 90% again, or if he becomes more anxious or confused.
Perfect, SBAR, Rosa. Honestly, very clean. Okay, anything else on Mr. Kim before we move on?
Yes, one more thing. His diet. Mr. Kim was made NPO after midnight. The doctor is considering a bronchoscopy this morning depending on how he looks.
Good. NPO. Let's make sure we're clear on that term because it is critical. NPO stands for the Latin phrase nil per os, which means nothing by mouth. When a patient is NPO, they cannot eat, drink, or take oral medications. Nothing goes in through the mouth. This is usually done before a surgical procedure or a procedure like bronchoscopy, because if the patient has food or liquid in their stomach and they are sedated, they can aspirate, meaning the contents can go into the lungs, and that is a very dangerous, potentially fatal complication. So if a patient is NPO, we put a sign on their door, we tell the family, and we do not bring them a breakfast tray. Clear?
Very clear. I already put the sign on his door, and I spoke to his daughter when she called at 5 a.m. I told her, no food, no water, no coffee until after the doctor sees him.
Well done. That family communication is so important. The family often tries to bring food from home. They want to help, they mean well, but we have to educate them. You handled that correctly.
Okay, moving to bed 6, Mrs. Delgado. 52 years old, she is post-op day 2 from her hip replacement surgery. Overall, she had a good night. She slept from 11 p.m. to about 4:30 a.m. Her vitals were stable throughout. Pain was managed.
Good. What did you use for her pain?
She received her scheduled ibuprofen at midnight. And then at 3 a.m., she called and said her pain was a 6 out of 10. So I gave her the PRN oxycodone that was ordered.
Okay, PRN. Important term. Rosa, do you want to explain that one?
Yes, PRN comes from the Latin pro re nata, which means as needed. So a PRN medication is not given on a fixed schedule. It is given only when the patient needs it, based on their condition at that moment. The doctor writes the order, but the nurse assesses the patient and decides if the medication is appropriate to give at that time.
Perfect explanation. And I want to emphasize that last part. The nurse decides. PRN orders give nurses clinical judgment and responsibility. You don't just give it because the patient asks. You assess. Is their pain level consistent with what they're describing? Are their vitals stable? Is it safe to give an opioid right now? Is their respiratory rate okay? Are they alert? In this case, it sounds like you made a good clinical decision. What was her respiratory rate before you gave the oxycodone?
16 breaths per minute, she was alert and oriented. Her O2 sat was 97%.
Good. You assessed before you medicated. That is exactly the standard of care. How did she respond?
Within 30 minutes, her pain was down to a 3. She fell back asleep around 3:45 and slept until I woke her for vitals at 6.
Great. Now, Mrs. Delgado is post-op day 2 from a hip replacement. That means one of our biggest priorities today is going to be mobility. Did the physical therapist see her yesterday?
Yes. PT came in the afternoon. They had her sit at the edge of the bed and stand with the walker for a few minutes. She did well, but she was nervous.
Good. And today they will likely try ambulating her, actually walking her down the hallway. Rosa, have you heard that term before? Ambulating the patient?
I have seen it in the chart notes, but I want to make sure I understand it correctly.
Of course. To ambulate a patient means to assist them in walking. It comes from the Latin ambulare, to walk. After surgery, especially orthopedic surgery like a hip replacement, we want patients moving as soon as it is safely possible. Early ambulation prevents so many complications: blood clots, pneumonia, muscle weakness, pressure injuries. A patient who stays in bed too long after surgery is at much higher risk, so ambulating the patient is not optional. It is part of the treatment plan.
I understand. So when the chart says ambulate TID, that means walk the patient 3 times per day?
Exactly right. TID. 3 times daily. And each time you ambulate Mrs. Delgado, you document it. You note the distance she walked, how she tolerated it. Did she get dizzy? Was her pain acceptable? Did she need significant assistance, or was she more independent? And you note her O2 sat before and after. Because sometimes patients who look fine at rest will desaturate when they start moving. We want to catch that.
That makes sense. I will make sure the day team knows to support PT when they come.
Perfect. Okay, let's wrap up. Any other patients before I officially take over?
Just a quick note on bed 9, Mr. Thompson. He is day 3 post-cardiac cath. He is doing well. No complaints overnight. His groin site is clean, no hematoma. His vitals have been stable all night. He is scheduled for discharge this afternoon pending the cardiologist's sign-off.
Good. Discharge teaching done?
I started it at 5 a.m. when he was awake. I went over his new medications and the activity restrictions. His wife was there and she was taking notes. I told them the nurse this afternoon would go over everything again and give them the printed instructions.
Excellent. That is good nursing, Rosa. You started early, you involved the family, and you set the expectation that there will be a follow-up. A lot of nurses wait until the last minute for discharge teaching, and then it feels rushed. The patient doesn't absorb it. You did it right.
Thank you. I was nervous about it, honestly.
That's okay. Being nervous means you care. That's not a bad quality in a nurse. It means you take it seriously.
Maya, can I ask one more question before I go?
Of course.
When I called the night resident at 2:15 about Mr. Kim, I used the SBAR format like you taught me. But I was nervous. My English felt slow. The doctor seemed a little impatient. Is that normal?
Rosa, yes. Honestly, yes. Some physicians, especially residents who are exhausted at 2 in the morning, can come across as impatient. That is not a reflection of your English or your competence. That is a reflection of the pressure they are under. But here's what I want you to remember. You had the information organized. You used SBAR. You knew your patient's O2 sat. You knew the intervention you had already taken, and you had a clear recommendation. That is your job, and you did it. Your English does not have to be perfect. Your clinical information has to be accurate, and yours was. So hold your head up.
Thank you, Maya. That means a lot to me.
You're going to be a great ICU nurse, Rosa. Now go home, rest, drink some water. I've got it from here.
Thank you. Have a good shift, Maya.
Always do. Always do. Let's do a quick vocabulary review before you go. Today we covered 5 essential nursing phrases. SBAR, your communication framework, situation, background, assessment, recommendation. O2 sat, oxygen saturation, the percentage of oxygen in the blood measured by pulse oximeter. NPO, nothing by mouth, used before procedures to prevent aspiration. PRN medication, a medication given as needed based on the nurse's clinical assessment. And ambulating the patient, assisting a patient to walk, a critical part of post-operative recovery. Practice these phrases. Use them in your charts, in your handoffs, in your calls to physicians. The more naturally they come to you, the more confident you will sound, and confidence in nursing keeps patients safe. See you next episode.